What I find interesting as I travel around the country and have for the last 30 years is the number of employed transactions is nearly back at the frenzied pace back in the mid-90s, when we all thought that capitation was going to rule the world, and unless you employed primary care doctors, no hospital would have patients. But one of the challenges that we have as a consulting firm is the calls we get from hospitals because they are concerned about the losses they have, or because they're looking to expand their physician employment, and yet they don't want to deal with the losses, and they're concerned about them. And so today we're talking about how to manage those losses, and it really requires, first of all, to understand what drives those losses. Why do they exist? And then second of all, putting them in context of, are these investments that we're making to get a return on the hospital side, or are there really improvement opportunities inside of the practices where there is a loss? And then perhaps most important is putting the cost of that physician strategy in terms of losses in the context of hospital return. So when we talk about hospitals developing physician alignment strategy, we suggest that hospitals think about physicians in the context of a total physician enterprise strategy, which includes hospital-based physicians, your radiologists and anesthesiologists, your pathologists, hospitalists, etc. It includes both, on the medical staff, it includes both the private and the employed physicians. But the physician enterprise encompasses so much more. It includes, if you have a faculty practice as a part of the hospital physician strategy, a large medical office building, visiting clinics, you might have community outreach, you may have set up a provider-based clinic at the hospital, specialty practices that you've deployed throughout the community. It may include urgent care. You may have acquired a large multi-specialty group, placed diagnostic or treatment centers throughout the community. It could include satellite clinics and even rural health clinics. When you look at that entire physician enterprise, what we're talking today about specifically is the physician payments that are made, and in particular, the economics of the employed physicians. When hospitals develop strategies for physician engagement, most hospitals will spend between 2 and 10% of their hospital revenue. So you take inpatient and outpatient revenue, and they'll spend 2 to 10% of that on physicians. A portion of that will go to pay payments usually in 1099 formats to the medical staff in the form of medical directorships, coverage and call payments, locums and service contracts, and then they'll spend another portion of that 2 to 10% on employed physicians. And we're going to talk a little bit later about how they make that payment, but essentially they're either not making a direct payment, but they're incurring losses on the physician practices, or they're making direct payments to a practice that they own and employ in the form of a subsidy, so the practice essentially breaks even. And some people will employ physicians and then deploy them in the context of hospital departments, and they essentially have now compensation as a part of a departmental cost. But in either case, hospitals must spend money on physicians in some format to essentially put their services to play in the hospital. As you can see there, there's a wide range. That chart on the bottom is a database of clients we have, and where we have both the hospital side data, we have how much they invest on the private side, and how much they invest in employed physicians, and you put that together, and you can see not only do they spend a variety of percentage of the revenue, but in terms of their strategy of how much is employed versus how much is not employed also varies quite a bit. But on average, it's about 2 to 10% is the range. It's about 5% on average, and it's about 50-50 split when you aggregate them all together. In terms of return, when you look at spending money on physicians, of course, without physicians, the hospital would have no revenue. And when you look at the amount of revenue a physician brings in, a physician will generate an average of about $1.5 million of hospital inpatient or outpatient net revenue. And of course it ranges depending upon the type of specialty. But when someone looks at the losses that a physician has or the payments that they're making to physicians for medical directorships and other kinds of services, of course ensuring that they're always fair market value and that they're in no way in payment for the volume or value of referrals in any way, and that the compensation is not connected to volume. But you've got to always put it in context of without the physician you wouldn't have the revenue, and when you begin to build your physician strategy and put pro formas together for employing physicians and begin to plot in some of the loss numbers we're going to talk about here in a minute, this is the kind of information you need to put in the pro forma to show that as you add 10, 10 new pulmonologists, of course you would do that only if you were in a very, very, very large urban market, that the average revenue per pulmonologist is about $1.6 million. So when you look at employed physicians, the average loss per employed physician today is about $100,000 and increasing. We've been monitoring the loss per hospital employed physician for many years, and we've been through 3 periods in the U.S. So back in the early 90s, when hospitals were buying doctors, I call it the react period because hospitals primarily were reacting to the idea that, again, capitation was going to take over. And then one hospital in the community would see the other hospital buy a couple of primary care groups, and then they would fear that they would lose their primary care groups, and so they would buy some. And the next thing you know, in some smaller to mid-range communities, you would see a frenzy over the course of a couple of years where many of the groups went from being private to employed very, very quickly. Then in the late 90s and in the early 21st century, we saw people beginning to recalibrate that strategy as we found out that capitation was not going to be, was not going to rule the world, and they not only did some people divest of them, but they began to shift in how they manage those practices. We're now into a reinvestment period, and the real big difference is in the earlier periods of employment, it was primarily in primary care, and today more and more hospitals are employing specialists. What was driving the losses before were very high prices paid for practice acquisitions, and today the prices tend to be fair market value on pretty much assets alone. Prior, they paid fixed compensation. Today, most compensation plans are variable compensation, either based on work RVUs or virtual private practice. Previously, hospitals viewed employed practices like profit centers, like they're going to buy this practice and run this practice over here, like somehow it's a separate department or entity. Today, hospitals view physician practices as strategic assets. And prior, there wasn't much know-how about how to manage these practices, and today more and more practice managers are being employed by hospitals to manage practices. So when we look at the cause of that $100,000 loss per doctor, you'll find that those losses can be identified across the 10 drivers of physician practice economics. There are 10 economic drivers of physician practice. It's productivity, rates, other revenue, staff cost, revenue cycle, payer mix, other cost, utilization, coding, and charge master. Those are the 10 drivers that drive the economics of practice. Across our client database of employed practices we've worked with over many years, this is the distribution where we find most of the loss. So for example, if you look at the chart on the right, you'll see that here's this average $100,000 loss, and about a third of that is driven from productivity problems. And again, I'm going to talk through these 10 drivers in just a second, but I wanted to show you where most of the loss lies. About a third of it in productivity, 18,000 of it in rates, 16,000 of it is in other revenue, about 9,000 in staff cost, etc. And then, so if you have about 50 doctors, you probably lose about $5 million. Or if you have 50 doctors and you don't report the loss, but you fund the group, you probably provide about $5 million of funding over to the group, and this is about what it would be for. I want to give you kind of a new way to view the loss, and that is what we call our A10 spread. And viewing the loss across all these 10 economic drivers of practice, it helps to answer the question that many boards of directors have and many senior hospital executives have who just haven't thought through the economics of this when they say, well, gee, why, my neighbor next door is a general surgeon and I don't employ him and no one subsidizes him, and yet you're a general surgeon and I employ you. Why do I have to write you a check for $100,000 to subsidize your practice every year? So this view allows people to kind of see what drives that. So on the far left-hand side is the typical picture of a physician group where they'll have $500,000 to $600,000 of revenue. They'll have about half of their revenue in cost and the rest in compensation. So if you are a 50-person group, you may have $30 million of revenue, $14 million of overhead, and generate about $15 million of compensation. Next thing you know, though, you're looking at an employed physician group, and you'll see that they lose $5 million. Well, the reason why is spread across there. And so if you'll take that revenue, and if the productivity issues weren't there, which we're going to talk about in a second, or the rate issues, you add that up, they would have $29 million of revenue. And if the cost issues weren't there, their costs would be more in line. So what you see on the right-hand side is probably a little bit about what you see on your side if you have employed physicians. You'll see lower revenue than normal. You'll see higher cost ratios than normal. And then you'll see compensation about the same, sometimes even higher. So that's kind of a new way to view your practice loss and kind of a way to explain to people why you lose that money.